Great talk, Jason. We do have time for Q&A session. We welcome two additional faculty members here too. One's Dr. Walid Ayoub, Director of Autoimmune and Cholestatic Liver Disease Program and Associate Medical Director of Liver Transplantation at Cedars-Sinai. And Dr. Harry Nguyen, my colleague, he's a transplant pathologist, joined the UCI about a year ago, and he's our assistant professor. So let's open Q&A session. Maybe I started it first. Dr. Loomba gave us a very detailed update about muscle D, and now, as you mentioned, that resmetirom is actually FDA approved and available to us. And Dr. Gutierrez gave us a very good talk this morning on that too. Maybe we want to hear from the panel their experience on how do you select patients in real world, how to get a prescription is a now new approved prescription and takes more time for prescription too.
Well, I can get started. So we have, as I mentioned, a resmetirom treatment clinic. What we're trying to do is have a common experience so we can make things easier for our patients. So all the 8 hepatologists, we refer to one clinic. We've got a template as to who are candidates for treatment of UCSD, typically based upon liver stiffness, for fibroscan, then ultrasound. And so all that is recorded. We have a note template because each insurance would want a note written in a manner that is consistent and makes it clear. We are not going for people who have earlier disease or milder disease or patients who have cirrhosis. So initially, we're only treating patients who we think are absolutely stage 2 or 3 fibrosis. And so it's very easy. We put in the NITs that we have. If they have a biopsy, when it was done, what was the stage of fibrosis? But typically, it's all based upon NITs. And as I mentioned, and then we send it through. We have a pharmacist who's helping us. He's linked to that clinic. And they review and then also look at DDIs or various medications they might be on. And then, whether we put in a BMI and their body weight, based upon that, we can see if they need a 80 milligram dose or 100 milligram dose. And all those things, along with the package, is then sent to the insurance, along with the prescription to the patient. And then there's a copay. Sometimes there's an issue that requires to be addressed as well. But we haven't had any major issues, except some insurances would require a biopsy, and in that case, we're ordering a biopsy and getting that done for the patient as well.
We have similar process. We don't have a dedicated clinic. It's from our general hepatology clinic. We use non-invasive measure for fibrosis assessment. We're only treating F2, F3. Before sending with a prescription we send out, we also send a report of the non-invasive testing we did on the patient. And very important, we document lifestyle intervention before, diet and exercise. Because one of the insurance company came back and asked the question. So now it's on the checklist for us.
Okay. Jason, you talk about endo-PPG. I'm very excited about that too. When I go to ESO meeting, I know in Europe, when we do this HVPG, it usually is done by hepatologists, not radiologists. Here we have IR do it. The question here is technical variation because you have to do wedge pressure. And we know that there's some kind of crazy reading too. We know that there's some variation. And now your direct measurement will be more reliable, I guess. Can you tell us a bit more technically trick or experience you want to share with the audience?
Yeah, so thank you for that question. So that has been, I think, one of the aspects of this procedure that have made hepatologists sort of more interested in it, that direct portal venous pressure measurement, as opposed to that indirect wedge to pressure measurement with interventional radiology. And I think what the Encounter study will show, which is the one that's happening in Europe right now, that's correlating HVPG with US PPG in patients either simultaneously or within a few days apart. I think that's going to be really interesting to see. One of the things that I will say is I've been with the interventional radiologies during these procedures, and they seem to fluctuate quite a lot, you know, especially with that indirect portal venous measurement. And so the number that they're reporting is really kind of quite a large range. And but you know, they usually land on one number, and but with the direct portal pressure measurement, it's so stable, you know. So the numbers after 30 seconds will be like, they might say 18 or 19 or 18 or 19, and then we'll say, okay, 18. With interventional radiology, the fluctuations are quite a bit more. And so I think, when some hepatologists sort of noticed that, they were sort of, I think, a little bit more convinced that this might be more accurate. The other thing that we've learned at DDW this year, there was sort of a roundtable with some prominent hepatologists who are sort of interested in this. Their take on it was, you know what, I know that you guys are kind of focusing on a PPG and comparing it to the gold standard HVPG, but maybe you should sort of, stop that approach, because they have doubts that HVPG, is as accurate as really it needs to be. And so now the effort is actually almost sort of like going back and sort of kind of rewriting this literature on kind of longer prospective studies looking at EUS PPG and decompensation. And so this industry-sponsored registry that we have funded now for 4 years will help answer those questions. So I think we're excited to see maybe, clinically significant portal hypertension isn't the 10 millimeters of mercury, or maybe it's a different number with PPG than HVPG. I think we'll see, but now I think there's enough interest from the hepatology community to sort of answer these questions.
Great answer. Since we have a new updated guideline for portal hypertension, clinical significant portal hypertension from ASLD, I think we want to do more PPG.
Yeah.
Okay. Yes, thank you.
Ask Jason a question. When you would not do a PPG, what are the limitations of the technology?
It's a great question. So, in those, I'm going to say, in every study that's been done on PPG so far, technical success has been very close to 100%, but in that less than 5%, that's not feasible. It's actually usually patients that are child C patients with distorted liver anatomy. Usually it's hypertrophy of the caudate lobe that sort of distorts things where we need to kind of puncture the hepatic vein. And so we have had cases where hepatic venous puncture is more challenging. Now, in those cases, though, it's almost always easy to hit the IVC. And so the debate has been, well, if I'm hitting the middle hepatic vein literally less than a centimeter from the takeoff of the IVC, and I just back up the needle into the IVC, is that really going to make a big difference? And so, interestingly, this device is FDA approved for only hepatic vein and portal vein puncture. And so IVC is, by the FDA, considered some sort of central vein that it's not FDA approved for. So this would be a sort of an off-label kind of measurement. And so, but, internally, our studies have shown that the difference between the middle hepatic vein or the left hepatic vein and hitting the IVC is probably 1 or maybe 2 millimeters of mercury difference. And so I don't think it's a huge correction factor that we'd have to make. And technically, IVC can be hit in almost every case. So I think there's very few cases where this can't be performed.
Do you find any difference between form of anesthesia used, and also what about respiratory motion artifact in terms of acquisition of data?
It's a great question. All of the studies that we've done at UCI have used general anesthesia. And so this has come up, and most of the HCPG data, has been on patients with moderate sedation, and so this is now the subject of a study that's going on right now, looking at moderate sedation versus anesthesia, and I think what we might find is the gradient difference isn't so much affected, but the absolute pressures might be. And the other thing that we now sort of discuss with our anesthesiologists is if they're going to do anything physiologically to the patient, do it before we get started with both measurements. And so if we get our hepatic venous pressure measurement, and then they do something physiologically to the patient, between the time we get our hepatic vein pressure and our portal vein pressure, I think that could disrupt things. So we're sort of mindful of that, but right now that's still a work in progress.
Thanks for your talks. Dr. Samarasena, good seeing you again. Quick question. So it's kind of going along the question that was asked earlier when you should not do the PPG. So if I have the option of a transjugular guided liver biopsy with PPG measured by IR versus if that option of doing EUS guided availability, when I should choose which and when I should not to. That's the first question. And then you just brought up the idea of accessing the IVC kind of off-label. Do you think EUS guided TIPS placement is a thing?
Yeah, so I'll quickly address the second one. So right now we're kind of looking into this. There is one view that you can hit the left portal vein in segment 4 and the left hepatic vein, and we are reliably seeing this. So basically one stick. In fact, there's a group in Virginia that's done over 200 PPG cases, and this is the way they do their measurements. Sort of one stick, they get the portal venous pressure measurement first, and then they move down just a couple of centimeters, hit the hepatic vein, and it's all sort of in line. So it's very tempting to think about maybe could there be one day where we could actually, visualize those two vessels and create some sort of shunt. But to answer your first question, I think a lot of these patients are getting endoscopies, for variceal screening and surveillance. And so if the patient is getting an endoscopy anyway, it might be reasonable, on one of those endoscopies to do this sort of endohepatology workup, which is, could be one or a combination of, liver biopsy, PPG, shear wave, and then, and there's some kind of new kind of palpation techniques that we're looking at. But so I think, in our system, I feel like Dr. Hu and Dr. Nguyen have really entrusted us with their patients, and they find the endohepatology workup sort of useful now because of the quality of the liver biopsy and sort of the direct pressure measurements. But I think, so I see this happening across the country now, where hepatologists are relying a little bit more on their endosonographers to get this information, and less on their interventional radiologists. But I think, it's sort of health system dependent. It's sort of the relationship that you have. One thing that I will say is, and I'm not sure if Dr. Hu or Dr. Nguyen feels this way, but about us, but when you send a patient to interventional radiology, you're getting a technician. And when you send a patient to me or Dr. Chang, you're getting another doctor that's going to take care of that patient on the team. And so I feel like, not that Dr. Hu or Dr. Nguyen needs our advice or, opinion on certain things, but we do get to know those patients. And I think we feel like we contribute a little bit more. The line of communication is a little bit more open than maybe, discussing a hepatology case with your interventional radiologist. So I think we do kind of serve that role as well, being part of the team.
I will say one of the most common indications that I do send patients to Dr. Samarasena, and I do feel like I send probably one a week to him, is that we do find discordant, non-invasive testing markers, and oftentimes that's one of the big reasons to send for not just PPG, but also the EUS shear wave. And we have found some discordant measurements where the transient elastography is off. Most often in cases, patients with not just elevated BMI, but when they're having central adiposity, and it makes, even with the XL probe that you have on your FibroScan machine, you're just not necessarily getting the best markers. And as we know, when you're doing vibration control transient elastography, it's tech dependent. You know, how diligent is the tech to get the right windows? And so if you have a tech who's been doing it for years and years, and you're working with, you know, Dr. Loomba at a world-class research center, that's different. But, you know, sometimes if we're not getting someone who's consistently doing these measurements on a routine basis, or the better tech is out sick and the other one's in, you know, these measurements can vary. So, you know, having direct access and having something that is most importantly now in the phases of being, you know, consistently repeated with good quality is something that we're looking forward to.
I just want to say that, Jason, we're also very proud of you and the work that you're doing. So I think this is good. Innovation, you know, happens, and sometimes you don't know where things might be. So it's important to continue to investigate. Just to your question that you asked, where it would not be beneficial, I think you could foresee a case where you would have significant caudate lobe enlargement. So that'll be in the setting of acute Budd-Chiari syndrome. So I probably would get a patient to intervention radiology, because you're going to get TIPS as one of the possibilities. And so they'll get to know that patient, and then, you know, you're going to have significant caudate lobe enlargement. So that would be definitely one place to go there, and not come to endohepatology.
I think just on the flip side, what Dr. Nguyen was saying, you know, you have a FibroScan that can be done. We do know that it's a 10% chance you can get an accurate number, but at the same time, it's non-invasive versus you setting in for an EUS-guided elastography. It's technically invasive. So by that time, I might as well get a liver biopsy. So in many situations, when I have kind of a situation that I'm in doubt. So it's just, it comes down to the non-invasive and invasive testing at that point.
I think if you have a good working relationship with your interventional radiology colleagues and you can reliably get them in for a procedure faster, then I think that's a good way to go. Sometimes the wait can be long. I know that in speaking with Dr. Samarasena, he's able to book cases a little bit earlier for certain rush procedures, and we are able to get them in reliably. So it's a matter of accessibility and what is accessible at your center. I would imagine that in most cases, your advanced endoscopists are going to be needed for EUS procedures, sometimes EMR, ESD. You know, you don't want to cloud up their schedule with liver biopsies either. It's a matter of resource utilization. So I mean, I'm fortunate to work at a center where Dr. Samarasena and Dr. John Lee are able to accommodate in any liver biopsies that I need if my interventional radiology colleagues can't get to them.
John, I have a question for you about ELISI. You mentioned a good point that IV salmeterol sometimes can cause liver toxicity. I think relatively uncommon. My question would be for those that we see those people with very severe ELISI, and you put a high dose of oral prednisone, and you even add CSF, they're still not responding. Will you do IV salmeterol, or you go some other options?
Well, it's an excellent question, and I really just wanted to alert people to the fact that IV methylprednisolone can be hepatotoxic. It's rare, as you would expect, because it's an immunosuppressant. You're giving it at high dose. And we've used it without any concern about hepatotoxicity in post-transplant patients forever, giving 1 gram on 3 consecutive days intravenously for acute cellular rejection. So there's a great experience about its rarity. However, it has come more to light in terms of the experiences of treating patients with grade 4 CTC-AE aminotransferase elevations or mixed cholestatic pattern abnormalities. So whether that's a more susceptible population in some way is very hard to know, because remember that all of these patients have had multiple treatments. Many have sort of a residual of the complications of those treatments, and they have kind of the systemic issue of immune activation that the ICIs have induced. So the circumstance is certainly different. I wouldn't fear it. I think that when you need intense corticosteroid immunosuppression, it still is the number one option. But one must beware that if you were to see it not effective or worsening, that you would recognize what it is and that you would change your immunosuppressive regimen. Now, what you addressed was those tough cases within that 2 to 3% that are illicit that don't really respond, and you keep on with a trail of addition of other immunosuppressive agents. And the whole field is kind of devastated by the anecdotalism of those therapies. And that is why I think that to make progress, I would like to see much more adherence to hepatology and gastroenterology consultation, making helpful decisions about what those third line agents would be after second line being MMF. Because when it's left in the oncologist's hands, it's a crapshoot, and we will never understand the potential benefit. And I already introduced the fact that the illicit is going to vary by cancer type and by the prior immunosuppression, by the presence of underlying chronic liver diseases, and by the presence of underlying DILI due to other medications, and the choice of the ICI. So there's so many variables in play here that we just have to be cognizant that the future lies in good data collection and analysis.
Great comments. Thank you, John. I see commonly refer from oncologists. When they see liver enzymes high, they just started steroids. They have their trial protocol. They start like a 60 milligram, cut down automatically, no matter response or not. Or a lot of time you see partial improvement of ALT/AST. Is that the way you see that too?
Well, I think we all do, but again, I'm speaking to the choir, so to speak, so we can all sing from the same hymnal. From the oncology standpoint, they see any abnormality and they attribute it to illicit. I hope I've convinced you that that's not accurate. That, in fact, that's not rational based on evidence basis. You really need a hepatologist and gastroenterologist's opinion, which could even be curbside, to be sure that you're first dealing with something that should be treated. And I also shared with you that not everybody with illicit needs treatment. It's based on the severity, and the severity can be ascertained by the inflammatory score, which is an HAI, kind of measurement in a liver biopsy. And I showed you that 2 out of the 3 didn't require corticosteroids and did quite well. It was a very large study. I could only show you the one algorithm. So hopefully that sticks in our memory bank, that we would like to work proactively with our oncology colleagues so that we're involved in these decisions.
John, one more thing, I'm finding is the experience of the pathologist reading the biopsy also is very valuable.
Yes.
Especially in the community where there's misclassification.
Well, I thoroughly agree. I think hepatopathology is, it's an art form, and we've heard about that from several different lectures and perspectives, especially when you look at NAS for muscle mass. So that said, when you look for autoimmune features, you have to step back and say, well, wait a minute. Everything you're looking at in an inflamed liver biopsy is immune mediated. So, we got to get off this idea that somehow immune mediated is different than anything else we're seeing. It's all inflammation. So the issue is, what is the type of inflammation? What's its organization? What are the targets, and what kind of necrosis or apoptosis are they undergoing? And that's where the specialist hepatopathologists really comes in, because they recognize that interface hepatitis is not pathognomonic for AIH, and they won't harp on that in a report. That is unfortunately too often done community-read biopsies.
Okay, if no question, on behalf of Symposium Planning Committee, Dr. S. William and Dr. Du Lai, we want to thank the panel, the faculty panel, excellent job, thank you all.